into pharmacokinetics, and let's see how it goes. Pharmacokinetics was mostly covered in chapter 2, but we'll see how it goes. All right, so pharmacokinetics is the basically how much of the drug is in your system, not what the drug does. So pharmacokinetics has nothing to do with, is the drug for anesthesia, is it for diabetes, is it for pain, is it for whatever, it doesn't matter. Pharmacokinetics is all about how much of the drug is there. How much of the drug is in your bloodstream is dependent on how much of the drug got into your bloodstream through absorption, and that's absorption through the wall of the stomach, through your skin, through your lungs, I don't know, you rub it in your hair, I don't know, however you try to get the drug into your body, that's absorption. Distribution means that it gets into your bloodstream and then distributes all over your body, right? Metabolism, again, in pharmacology, metabolism refers to the biotransformation of the molecule, so either to deactivate it or to activate it in some cases. And excretion, which for most cases is going to be through the kidney, through urine, right? I always have a question on the test, which is like, what are the processes of pharmacokinetics? And then I have absorption, distribution, metabolism, and excretion, and then some other words that kind of sound the same. So don't just memorize the names of the term, make sure you know what it means, because then that kind of thing will be obvious. All right, so let's, again, I'm just gonna see how you do on these questions. I don't expect you necessarily to know the answers, but it'll give me an idea of like sort of how much you read of the chapter and how much you have it on top. That way we don't waste time on stuff you know. Do you have a question, or you just okay, just excited. Okay, all right, so let's ask, here's a question. So the diuretic furosemide, which is also known as Lasix, is an acidic drug, right? It's an acidic drug. If a patient is taking antacids with their Lasix, the Lasix takes longer to start working. And this is because why? So now you have your letters. Give me why you think this is. It's not the greatest written question, but. And if you don't know the answer, that's okay. All right. Okay, got one vote. Necessarily a democracy, but all right, okay. So we have about a third said that D is the correct answer, which I would agree with. Acidic drugs are best absorbed in an acidic environment. So if you make the stomach, if you're taking Lasix orally, if you're taking a PO, then it's going to be best absorbed if the pH of your stomach is low, if it's acid in your stomach. So by taking antacids, a patient is raising the pH of their stomach, and now it's going to take longer for that drug to be absorbed. Now I have an entire video about this, so I'm not going to go much into it, much detail today, but just make sure you look at the video and make sure you have on top of it. You're on top of that. Let me just give you basically, here's sort of the upshot. Is an acidic drug, and drugs are called acidic, and this is not in your handout, so I don't know. I think it's in the other handout that you get when you watch the video. But a drug that is acidic drug, meaning the pKa value, remember the Henderson-Hasselbalch equation? Oh my God, that was like 1,000,000 years ago in chemistry, right? So don't worry about it, I'm not gonna make you do it. But any molecule is defined, has a pKa value, and that defines it as an acidic molecule or a basic molecule. And almost all drugs are weak acids or weak bases. And so an acidic drug, a weakly acidic drug, in an acid environment, meaning the pH environment is less than 7, is lipid soluble and is absorbed well through cell membranes. Okay. So an acidic drug in an acidic environment is absorbed through membranes. A basic drug in a basic environment is absorbed through membranes. And if you switch them, then those become water soluble. So again, this is all in the video, and take a look at that if you're a little bit rusty with your chemistry. That should help you sort of get back to that. And I'll leave that up here while I ask you the next question. So again, I'm not going to go through that in class. Take a look at the video, and then if it's still not clear, then we'll talk about it next week. So not a problem. All right. So why did the FDA put out a warning to not crush hydrocodone pills? So hydrocodone is a opiate like morphine or heroin. And you know, you always hear about people dying of drug overdoses. It's usually from heroin. Does any of you guys know why you die from a heroin overdose? not from personal experience, just like do you know? Part of it is the heart rate, but mostly it's that you stop breathing, because opiates at high doses inhibit the medulla oblongata, which is what keeps you breathing. All right. So crushing, so why would they, this was just about a year ago, they put out a warning, do not crush these pills, because people were crushing the pills. But it increases absorption of the drug. But why? Why would it increase absorption of the drug, and why would somebody crush their pill? Because it's smaller particles, so right, so it dissolves really fast, right? So it's absorbed easier in the stomach. Why would patients be doing that? To get high, right? So if you crush it, instead of having a slow absorption from the stomach slowly into your bloodstream, you get a fast. And I think some people were crushing them and inhaling them. Again, I don't really understand the inhaling. If you're crushing it, it's going to be absorbed from your mucous membranes anyway. I don't know. But the problem is if you're not prepared to have a massive dose of hydrocodone all at one time, you stop breathing. That's not good for you, because then you die. So you don't want to die. All right, so this idea that obviously a pill is going to take longer to absorb in your bloodstream than a powder or a liquid, just because a powder or a liquid is already kind of halfway being dissolved. Okay, all right. We would expect a stomach filled with food will what? The onset of action of a given drug. Onset of action is when it starts working. Okay, all right. We have we have about 80% consensus. It increases the onset of action. In other words, if your stomach is full of food, the answer was B. So if your stomach is filled with food, then the drug has less chance to be absorbed by like the wall of your stomach, right? Because if you have an empty stomach and you take a drug and it's dissolved, it has everywhere that the drug sloshes around against your stomach wall, it can be absorbed. But if your stomach is filled with spaghetti and meatballs, then if you're trying to, the drug has to like get past the spaghetti and meatballs in order to be absorbed. So having a full stomach will make it take longer for the drug to start working. So we'll increase the onset of action. We'll increase the time until the onset of action. I think would have been a better way to write that. So that's just a not very well written question. Do you get the idea? Right? And I know, I mean, like you may know just, I'm not I don't drink, generally speaking, but the morning I got married, I was very nervous. And I'm getting dressed in the giant, this was the 80s, so my dress was huge. It was covered with sequins and the like puffy sleeve, the whole thing. And I'm getting dressed at this friend's house, and I'm like nervous. She's like, here, have some champagne. I'm like, okay, totally empty stomach. By the time I got to the church, I was completely drunk. Completely drunk. And we get to the reception, and my husband, he goes, I would like to toast the bride, but she's already toasted. So it's like my one act of public drunkenness was my own wedding. So I'm sure if I had breakfast, maybe it wouldn't have gotten so bad, but there you have it. All right. So, and so again, surface area, contact time. You know, if your stomach's empty, then the drug has a chance to be absorbed. All right. Route of administration. So what route of administration gets the drugs to the bloodstream the fastest? Fastest. And then I'm going to ask you the slowest. So which is the fastest? Okay, I think we have agreement there that IV would be the fastest. And what about the slowest? Okay, we got about 80% agreement here. Yeah, orally, PO will be the slowest. Right? And you know, that's because of a variety of factors. It just depends on the drug. Again, an oral drug that is crushed or in liquid form and is very acidic drug, so it's very lipophilic and it gets absorbed through the stomach wall, that might get actually absorbed a little faster than an IM injection. But most drugs are not like that, and they're pills, and a lot of them don't get absorbed until they get to the intestine. And so on average, the oral route would be the slowest route in terms of how fast the drug gets to the bloodstream. Does that make sense? So far. All right, a tiny molecule is easier to dissolve into the tissues than a big one. And then solubility. You'll notice when you look at generic names, sometimes it'll say like propranolol HCl, or it'll say sodium, you know, whatever. And that's because some of the formulations are made as salts just so that the drug dissolves a little faster. That's all that is. Okay. All right, here's the distribution. So that's absorption. Getting the drug from wherever it is to your bloodstream. That's absorption. distribution is going throughout the body. All right, why is it difficult to treat a brain abscess? And this one I think may have more than one answer, even though there's 3 answers. So, this has more than one answer, so it's either 2 or 3 answers. Yeah. Okay. I would agree. What do you think? Okay, there's 2 answers. Like my dad had a brain abscess about 4 years ago, 3 or 4 years ago, and never did figure out what it was and what it was from. And the problem is getting antibiotics into your brain is a problem because of the blood-brain barrier. So you remember the blood-brain barrier, I hope, that's because the brain is immune privileged, which means that it's sort of protected from your own immune system. There's 2 other tissues that are immune privileged. Anybody? Nope. That you're thinking of the placenta. Yeah, the testes and the eyes. Right? So like when I used to be an eye doctor, if someone had an eye infection, we have to inject antibiotic directly into the eyeball because there's like very difficult to get the antibiotic in. So that's one problem. And the other problem is that there's no blood vessels in an abscess, sort of by definition. So an abscess is where you have infection, and the what happens is you get a really bad infection, and an abscess is sort of like a cherry cordial with the outside, the chocolate coating being the scar tissue and inflamed tissue, and the cherry center being all pus and bacteria and dead cells. So an abscess, because it has no blood supply, because it's just pus and dead cells, it's very hard to get a drug there. By the way, if you have, if you want to describe a problem that a patient's having, you look at some part of their body and it's all covered with pus, what is the adjective that you use, and how do you spell it? Can't write pussy. Right? It's all pussy. No way to spell it. It's, well, you could say exudative, but usually it's purulent. I think it's P-U-R-U-L-E-N-T. Anyway, just don't ever write pussy because you'll get written off. Don't do that. Not by me, but
to get that.
Yeah, because it's like, well, how do I write this? I don't know. All right. The same thing holds true for some tumors, because you know cancer. The reason you have that cancer is bad is because the cells grow out of control, and sometimes you can have a tumor that's growing so fast that the cells, as the thing gets bigger and bigger, it's actually growing faster than the blood vessels. So the inside becomes all necrotic and nasty, and so once again, it's very difficult to get chemotherapy into that part of the tumor. For my dad, what happened with him eventually was they just had to drill a hole in his skull and put a tube into the, what's it called, the ventricles inside your, you know, the thing that looks like the Starship Enterprise?
Yeah.
You know what I'm saying? Yeah, see, eye doctor at Minsville. Okay, so, it's the thing that looks like the Starship Enterprise.
So like the olden days, they drilled into his skull to get the black death
Olden
out.
days, it was like 2 or 3 years ago.
No, right, but like the olden, like medieval times, they would do that to get like evil spirits out, right?
Right, yeah, like if you had schizophrenia, they would drill a hole in your skull.
Yeah.
In the hopes that that would help in some way. Yeah. You know, why not? They didn't have studies back then. So. All right, so here's another question. Why do extremely obese people take a long time to wake up from general anesthesia? So, what's your answer there? All right. Well, I think I misled most of you. The answer is B. What? The answer is B. Well, your brain is made of neurons and myelin. And what's myelin?
Fatty.
It's all fat, right?
Yeah.
So anesthetic drugs, I mean, what is the site of action of an anesthetic drug that's meant to put you to sleep? Your brain, right? Because, I mean, if you put anesthesia in your elbow might get numb, but it's not going to put you to sleep. So drugs that are meant for the brain, any drug that works on the brain pretty much crosses the blood-brain barrier, and a lot of them are quite lipid soluble, because they're meant to go to the brain, like a lot of those inhaled anesthetics. So So what happens if you have a patient that's like 800 pounds is that, first of all, it takes for a really long time to put them to sleep because the anesthetic that you're maybe having them inhale or you're injecting goes to the bloodstream and then has to go through the whole body and eventually get to the brain. But you know, your brain's only like 12 pounds, and if you have 600 pounds of fat on your body, then the drug goes to the fat. And similarly, when patients you want the patient to wake up, you turn off the anesthesia, and you're sitting there waiting for the drug to be metabolized and excreted. You have to wait a long time because it has to leach out of the fat. So that's a really extreme example of sort of different distribution in the body, but it is clinically relevant. The liver metabolism, again, liver metabolism of drugs is not the same as a slow metabolism, and that's why I gain weight. That's a different. You all fell for my evil trick. Whoa. All right, so here's another question. Patient with reduced blood protein levels, so like albumin, something like that. So either they're starving, they're anorexics, they're burn victims, lose a ton of protein. And you're going to give them a drug that strongly binds blood proteins like albumin. What are you going to have to do with the dose? So you have two patients. You have, you know, a normal patient. So we'll call them the normal patient will be Norm, the normal patient, right? Who's just a guy. And then you have sort of a hefty guy, shoulders. And then you have, I always have to think of a name, and I only ever think of a, huh? Norma? No, I think Carl. I don't know. Whenever I have to think of a random name, it's always Bob, Steve, Carl, or Joe. I don't know why. That's like, those are always like the names of EMTs, right? Paramedics always are named. They're all named Tom and Mike and stuff. All right, so anyway, we'll have Carl, the skinny guy, who is, let's say he's anorexic, poor guy. All right. So if the dose for Norm is 100 milligrams of whatever drug it is, you know, what are we going to do with this guy? So are we going to give him a higher dose, a lower dose, or the same? They both weigh the same. They're both 70 kilogram guys. All right? So we'll imagine that he's like 8 feet tall, so 70 kilograms isn't good enough for him. So what do you do? Increase, decrease the dose, or keep it the same? We have about 70% agreement here. All right, so here, let me show you the situation. Now, there's a bunch of drugs that bind protein in the bloodstream. Usually it's albumin, sometimes it's other proteins, right? So there's a certain amount of albumin that's normal to have in your bloodstream, and the albumin is there for a variety of reasons. Do you guys remember anything about that? Albumin? It has a couple of functions. The first one is that it keeps the fluid in your blood vessels. So the albumin, it acts like an osmotic force to hold fluid in your blood vessels. So you probably have seen these, you know, dreadful, horrifying photographs of people starving in other countries, and they show these little kids that are starving, they're like skeletons, and their stomach is all bloated. And that happens because when you have very low protein in your diet, your albumin level goes down, and when the albumin level is too low, it's very hard for your blood vessels to hang on to the fluid inside them, and the fluid tends to seep out into tissues. And what happens in that situation is the fluid is actually seeping into the peritoneal space. So their stomach's actually just full of fluid, because they don't have enough albumin. All right, so you're going to see situations where patients have reduced albumin when they've either just gotten over a really bad illness, because their body needed extra protein in order to like fight the infection or to be, you know, to be healed from being crushed on a motorcycle or something. And then people who are starving and burn victims lose a ton of albumin. So if we have two patients, there are two guys, they both weigh the same, but this guy has maybe half the albumin of this guy. So these are my 4 molecules of albumin that this guy has. We're going to say he has half the amount of albumin. And let's give them both a drug. Okay, so I'm going to give them each a dose. Let's give them each 100 milligrams, so we'll give them 5 20 milligram tablets, okay? So we're going to give 5 tablets to this guy. We're going to give 5 tablets to this guy. So in this patient, there's a binding site on each molecule of albumin for this drug, right? Same thing here, right? Which means that in Norm, the normal guy, you've given him 100 milligrams of the drug, of which 1/5 of it is free. The drug has to be free if it's going to be able to go into tissues and bind receptors. So this is the normal situation where you just expect that about, in this case, 80% of the drug that you gave is bound to albumin. And that's okay, that's the normal situation. But here you have this guy, and you've given him the same dose, of which 40% of it is bound to albumin, but now there's 3 times the amount of free drug in his body. So what you've done by giving them the same dose is you've given this guy 3 times the dose. Does that make sense? Right? So in this guy with the reduced albumin, you're going to have to give him a reduced dose, particularly if it's a drug with a low therapeutic index. Right? A drug with a low therapeutic index, it's very easy to poison the patient because you only need to double, triple the dose before you start getting troubles. Okay? Does that make sense? Now, something that's not in the handout, but I should mention also, is what if you have a situation where you have the normal guy, okay, and he's on a drug that is binds albumin. No, let's give him a leaf. All right. All right. Okay. And now we give him a second drug that I didn't. Did I need a question? Nope, I didn't. I was thinking maybe I had a question for you, but I don't. All right. So now we're going to give him a second drug. All right. That also binds albumin. So what's the problem going to be? So if this drug wants to bind the same binding site, right? So it wants to bind here, that kicks this one off. Right? Similarly, if this one decides to bind here, that kicks this guy off. Right? So if the second drug you give binds the same binding sites, it's going to kick off the first one, and now the patient's going to get toxic on their first drug. This is one of many different kinds of drug interactions. If 2 drugs are protein binding and you give them at the same time, then one of them or both of them are going to be, the doses are going to be too high. You're going to need to lower the dose. So I like to think of each albumin as like a bus that goes around the bloodstream, and there's only so many seats on the bus. So if everybody wants to get on the bus, if everybody wants to bind albumin, there's just not enough seats, you're going to have to lower the dose of one or both. And it actually, it's actually, again, like in the receptor business, it's actually a physical thing where like the receptor actually physically like fits like a Lego into the receptor. And same thing here. These are binding sites on this big protein. Usually there's only a couple binding sites per molecule of protein, and there's only so much space. So again, when we're talking about what's called the bioavailability, the amount of drug that gets to the bloodstream, that has to be the amount of drug that gets to the bloodstream and is ready to go. So it has to be free, it can't be bound up to anything else, it has to be ready to bind receptors. Okay? Okay. All right, we're going to talk about crossing the blood-brain barrier. Don't worry about volume distribution, that's later. All right. We start at 12:30, right? Why don't we take a break now? Take a quick break. We'll come back in like 5 minutes. And then we'll talk about metabolism, and we'll do some enzyme practice things. If there's anything in the end of the handout that you had questions about when you looked over, let me know, because we aren't going to cover the last couple of pages. That's sort of something to do with our phones. Okay. Let's see if this actually recorded.